I'm Dr. Shravani Durbhakula, and I'm the Pain Medicine Fellowship Director at Johns Hopkins Hospital. Today I'm here with two distinguished physicians, Dr. Stephen Cohen, Chief of Pain Medicine at Johns Hopkins, and Dr. Friedhelm Sandbrink, the National Program Director for Pain Management at the Veterans Health Administration. We will be discussing a new set of guidelines for pain practices to utilize in the context of the COVID-19 pandemic. These were created as a collaboration between several academic institutions, the Veterans Health Administration, and the Department of Defense. They are supported by the American Society of Anesthesiologists and endorsed by multiple pain medicine societies and now accepted for publication. Welcome, Dr. Cohen and Dr. Sandbrink.
Thanks, Shravani.
Nice to be here.
Friedhelm, the last few weeks have been new territory for all of us. How has the pandemic changed our practice of pain medicine? What new challenges does it pose?
Well, the COVID-19 pandemic emergency truly creates a challenge, right? We on one hand have to balance the need to relieve the suffering of the patient, but also, the societal burden needs to be taken into consideration. But we have to balance that with the need to protect the most vulnerable patients from the infection, as well as providers who take care of these patients.
Steve, you are the first author on the guidelines. Tell me about the guidelines you wrote, and why in pain medicine do we actually need our own set of COVID guidelines?
Access to pain management has been described as a fundamental human right, but access to pain management does not always equate with effectiveness of treatment. Pain cuts across all specialties, so that if you opened up an internal medicine, a surgical, a family practice journal, you would very likely come across an article on pain. Pain has been linked to the opioid crisis. So it's the subjective nature of pain, the wide variability in how people react to pain, and the enormous consequences of undertreatment that really underscore the need for guidelines.
Definitely. I love that you call it a fundamental human right. So our specialty is not truly elective. We must continue prioritizing the treatment of pain during the pandemic. The guidelines recommend triaging visits into 3 categories: elective, urgent, and emergent. But how do you make those decisions? What is considered elective, urgent, or emergent?
That really is the million-dollar question and why we need guidelines. So we consider many factors, including acuity, disease burden, the likelihood of benefit, risks to both providers and patients, alternatives. We consider psychiatric factors. For example, a patient who is depressed and is not able to work might seem to be a great candidate for, a pain intervention. Yet, that patient is also much more likely to fail that intervention.
At the same time, I think, Steve, you also have to think about the possibility that somebody who, when they don't get a procedure, may need to actually start opioid medication. And we would want to reduce the reliance on opioids itself. You also have to take into consideration logistical factors. What's the setting of the practice? The local and the state regulations. And lastly, I think very important is also the need to conserve, personal protective equipment. The masks and the gowns that we are really, that we need to protect and have available for our providers in the field.
So exactly, this is very consistent with what the American College of Physicians recommends, where providers consider context, they consider logistics, and also the likelihood that someone might seek, emergency medicine services.
Absolutely. So these are great points that were just brought up. I want to call our attention to 2 specifically. Opioid medications could potentially depress the immune system. So in the context of a pandemic, that's something we want to be particularly careful about. And emergency services. So if a patient is going to the emergency room or becoming suicidal because we're not able to provide pain treatment, we aren't actually doing any benefit by denying that patient care. So let's walk through some specific examples. This can be very confusing. How would you simplify this triage process for perhaps a trainee, or break it down for your staff?
So I'll go over some of the urgent procedures, and I think there was the most controversy about these procedures among the different co-authors and members of the societies, because these are often affected by factors that have to be decided on a case-by-case basis. So some of the things that we would consider urgent would be neurolytic procedures for refractory cancer-related pain. And so neurolytic procedures are actually considered to be towards the top of the World Health Organization analgesic stepladder. But as you know, many people are starting to utilize those much earlier. So even before higher doses of opioids. Another example is epidural steroid injections for acute disc herniation associated with serious or progressive neurological benefits. Possibly vertebral augmentation, although the evidence for that is mixed. Our colleagues from NANS said, replacement of neurostimulation devices in which there's a high likelihood that abrupt cessation of therapy will lead to decompensation should be considered possibly urgent, again, depending on patient-related factors. Sympathetic blocks for early CRPS, so sympathetic blocks in this context can have not only therapeutic purposes, but also facilitate PT and have diagnostic benefit. Spinal treatments for spinal pain, where there's a high likelihood that someone will develop physical or psychological disability or utilize emergency medicine services. And several other things, including possibly debilitating nerve entrapment syndromes and maybe some types of headaches.
So in regard to, I think, the conditions that are emergent and would really require proceeding with the procedure, I think we should think particularly about complications of pain interventions, such as dislocations of the dorsal root ganglion stimulators or of spinal cord stimulators, especially if there's any kind of neurological compromise. But of course, also complications such as wound infection, wound dehiscence, where truly a local treatment is absolutely needed at that point. I think another example is an epidural blood patch in a patient who has intracranial hypotension that may be a complication after a neuraxial procedure. Lastly, I think also patients who have intrathecal pumps, they obviously need to get filled and they need to be maintained. So I think those are in particular, as you can see, complications of neurosurgical or of pain interventional procedures that the patient may experience.
Right, exactly, because somebody with an intrathecal pump filled with opioids can experience withdrawal, and withdrawal from baclofen can be fatal, actually.
That's one more condition. I think patients with a rib fracture or patients who have truly severe chest pain, they can truly benefit from an epidural or paravertebral catheter that works quite well immediately.
Given that there are cases we must do, we are going to eventually see patients who have COVID that we have to treat, or who are high risk for getting COVID who we have to treat. So what risk mitigation strategies should clinics employ in this type of a scenario?
Well, there's a number of things that can be done. The need for an escort can be waived, or escorts can be asked to wait in the car in the parking lot. Patients can be brought straight to the procedure room, so to minimize the amount of contact. And they can actually be recovered in the procedure room and then discharged either home to quarantine or to the hospital. The most experienced provider should be doing the procedure. If the patient is at high risk or is known to have COVID-19, then either an N95 face mask should be used, or if fit testing fails or they don't have one, or the provider has facial hair, they can use a powered air purifying respirator. Even patients who are not known to be high risk may be asked to wear masks.
Steve, you mentioned that the procedure should probably be done by the most experienced person. I think what we have to keep in mind is that really you want to minimize the number of people who are actually exposed. So that means on one hand that you have to think about the providers, right? If there's only one person needed, then that's what you should utilize. But in particular, we have to think about the support staff in the office, right? Maybe you have less people in the reception and you rotate them, so there's only one person there at a time. The goal is really to minimize exposure to COVID.
Another big talking point amongst pain physicians right now is the use of steroids in pain procedures and the risk-benefit ratio, given the possibility of immunosuppression. Steve, can you comment on that?
So it's ironic, Shravani, because questions about the use of steroid were really what prompted the development of these guidelines. So here are the facts. So steroids do suppress the immune system, often for 3 to 4 weeks, occasionally longer. Steroids have anecdotally been linked to infection, but causation has not been proved. There is a very, very large retrospective study out of the Mayo Clinic, and what they did is they looked at more than 15,000 people who were vaccinated against influenza. Some of the people ended up having steroids injected into joints and some did not. And the people who had steroids injected into joints were a little bit more than 50% more likely to develop influenza. So there could be a risk. But here are the other things that are important to know. Steroids are often used for procedures where there's no evidence of benefit, such as trigger point injections. And even when there is evidence of benefit, such as for epidural steroid injections or injections into joints, people typically use dosages that exceed the ceiling effect. So in other words, for epidural steroid injections, clinical trials usually use 50, 80, sometimes 120 milligrams of triamcinolone or dipomethylprednisolone. But guidelines from the World Institute of Pain suggest, that maybe 20 milligrams is the right dose for an interlaminar epidural steroid injection, and possibly doses as low as 10 milligrams for transforaminal epidural steroid injections. And the same thing holds true for joint injections. It's also important to remember that chronic pain by itself and chronic opioid therapy may also suppress the immune system.
Amidst all of this craziness and frenzy, we still have to remember to be evidence-based and continue evidence-based practices. Let's talk quickly about the continuation of NSAIDs for our pain patients, as this has also been a big topic of discussion recently.
So the bottom line is that if NSAIDs are indicated, they should be continued. And where this controversy arose was there were anecdotal reports of maybe 4 people who had COVID and they took ibuprofen and their condition deteriorated. So it led the French health minister to actually issue a warning against the use of ibuprofen or NSAIDs in general in people with COVID. Since then, the World Health Organization and the US Food and Drug Administration have said there really is not evidence. However, it's important to recognize that NSAIDs can mask some of the symptoms of COVID, including fever, headache, myalgias.
For elective visits to minimize exposure, a lot of practices are turning to telemedicine. What telehealth options do we have, and what advancements have recently occurred in the context of the pandemic?
Yeah, so we have really greatly increased the use of video visits. In the VA, we use a system that's called VA Video Connect, we call that VVC, which is a secure messaging system. But we are now allowed also to use other private systems such as Facebook Messenger, FaceTime, and Skype. There are a couple of things to keep in mind. In regard to the billing, Medicare now allows us to bill similar or actually equal to an actual face-to-face visit. Trainees can now also do video visits. Of course, there's also the option of phone consultation or phone visits if needed. But there are a couple of rules to keep in mind. On one hand, not all states allow video visits across state lines. In fact, there are only 12 states that allow it to do so. In regard to opiate prescribing, that always has been a particular challenge. In this regard, the DEA actually relaxed the rules and allows us now to use a video visit as long as it's an audiovisual, two-way communication with the patient to replace, during this emergency, an in-person visit.
I would also add that if a physician was planning on starting opioids or increasing the dose for more than a short period of time, more than a week, that we would recommend coming in.
patients also do have access, to electronic pain diaries that we're utilizing, where a physician can remotely look and monitor a patient's pain function, things like this. And just in regards to trainees, as a fellowship director, I'm just going to make one clarification, which is that trainees can absolutely be involved in telemedicine visits. They just have to have the supervision of an attending physician, just like they would in a normal clinic scenario. Steve, Friedhelm, any key takeaway points that you want the viewing audience to leave with?
First, it's important to recognize that these are guidelines. They're not standards. So they're basically a roadmap that clinicians can follow. And ultimately, it's up to clinicians to decide what's best for their practice, and clinicians and patients to decide what the best treatment is for individual patients. So we provided, best practice recommendations here, but it's important to know that, federal and local regulations supersede what we say, and because they consider conditions on the ground.
From my side, I think we just always need to keep in mind that the provider-patient relationship is just so important. And we have now the technology to stay in touch with our patients remotely through video health, through phone contacts. So while we may not be able to see the patient in person, we can maintain this contact with them, and that relieves, I think, a lot of pressure and stress on the patient side.
And so we want to take a second right here to thank everyone for everything they are doing for our specialty and for medicine during this pandemic. We recognize that these are difficult times. Thank you for joining us. Thanks, Dr. Cohen. Thanks, Dr. Sandbrink. And we hope you take a look at the publication.
Thank you, everyone.
Thank you.